This is Dr. Mansoor Madani, Chairman, Department of Oral and Maxillofacial Surgery at Capital Health System in Trenton, New Jersey, and Associate Professor of Oral and Maxillofacial Surgery at Temple University in Philadelphia, Pennsylvania. Welcome back to the final chapter of my presentation on pain management, opioid, as well as substance use and abuse. But now let's review the Pennsylvania guideline on the use of opioid in dental practice. Of course, these guidelines are not limited to Pennsylvania, as I have added the CDC recommendations as well. And it could apply anywhere a medical or dental practitioner manages pain or writes a prescription for treating pain. First, let's look at the guideline being established by dental boards. It is highly recommended and even required by some dental boards, including Pennsylvania Board of Dentistry. In order to renew dental licenses, the practitioner must receive continuing education on pain management, continuing education on substance use and abuse and addiction, continuing education on identifying patients at risk of substance abuse disorder, counseling patients about side effects and addictive nature of opioids, counseling patients about proper storage and disposal of opioids, appropriate prescribing guidelines regarding quantities and duration of opioids, use of opioid alternative, use of prescription drug monitoring program, and partial filing of prescriptions should be also discussed. But why we need these training? It is because dentists have played an important role in opioid crisis. Look at these CDC statistics. Dentists prescribe between 1 and 1.5 billion doses of opioid annually. Dentists account for approximately 12% of all opioid prescriptions. Until recently, over 40% of dental patients were prescribed opioid following tooth extraction. The rate among adolescents is higher at 61%. The average prescription is for 20 tablets of hydrocodone with acetaminophen or Tylenol number 3. Dentists are the leading prescriber to young people 10 to 19 years of age. 52 million opioid doses taken non-medically can be traced to dental practices. Adolescents' non-medical uses of prescription opioids, 27% obtained from dentists. 96% of prescribers instruct patients to take prescription opioid as needed. Patient given opioid following dental surgery reported 54% of prescription left over following cessation of pain. As I discussed in the past, the most common abused opioids are heroin, morphine, codeine, fentanyl, meperidine, oxycodone, and oxymorphone. I ask you to refer back to the part 1 and 2 of my presentation of pain management for much detail about those drugs. Personally, the history of discovery of these drugs for me was very interesting, and I encourage you to listen to those segments as well. If you subscribe to our channel, you would be updated to new courses as well. Now, let's begin our presentation. Obviously, before starting pain management, we need to conduct and document a comprehensive medical and dental history. We need to document and verify current medications patient is taking and for what reasons. This is also important to know because of drug effects, drug interactions with medications that you're writing. Importantly, you should ask the patients the time of the day that they take their medications. In many states, you can access patients' complete medication history online. Use PDMP or Prescription Drug Monitor Program effectively. Perform a comprehensive examination. Medical history should include complete list of medical illnesses. We must be familiar with the most common illnesses such as hypertension, diabetes, anemia, cardiac issue, asthma, cancer history, any chemotherapy or radiation therapy, and so on. Knowing the basic medical treatments and lab values are essential in establishing what you would do next in your treatment planning. Many times patients present with rare illnesses, which they can tell you about it, or you can go online and find out about them. As far as the medication history, we need complete name, dosage of all medication, including non-prescription and herbal supplement that patients take, not only on a daily basis, but monthly, quarterly, or even annually, as some of these medication, they are given once a year or every 6 months. Know what precautions to take for each of those medications for drug interaction. Smoking and use of recreational substances should be explored. History of drug addiction or recovery are crucial in prescribing any narcotic or administration of any anesthetic medications. Although I covered the PDMP or prescription drug monitoring program in other sections of these presentations, but I feel this program is so valuable that it's worth revisiting it here. The PDMP is a program that collects information about controlled substance prescription drugs that are dispensed to patients within the states. It has a couple of benefits. First of all, is used to increase the quality of patient care by giving prescriber and dispensers access to the patient's controlled substance prescription medication history. The other benefit of it is to help regulatory and law enforcement agency in the detection and prevention of fraud, drug abuse, and criminal diversion of controlled substances. What we have to do as practitioners is to discuss patients' previously prescribed medications to make sure he or she is aware of how opioids are used in pain management and the risk and harm associated with therapy. Engage patients in a discussion about when it would be appropriate to taper off opioid or use lower dosage of opioids. And also, we need to monitor the total morphine milligram equivalent per day, which I have discussed in previous presentation, and it compares the strength of an opioid compared with morphine. PDMP could easily be used by practitioner to monitor for signs and evidence of misuse and or risky behaviors, to refer a patient to substance or opioid use disorder treatment if necessary, and also to avoid any potential harmful drug-to-drug interaction, for example, opioid and benzodiazepine, or an opioid and a stimulant. Also, PDMP could be used to discuss alternative pain management strategies before referring a patient to substance use disorder treatment. In short, we have to make sure to review the patient's history of controlled substance prescription using PDMP data to determine whether the patient is receiving opioid dosage or dangerous combination that put him or her at higher risk of overdose. PDMP is an electronic database that tracks controlled substance prescription in a state, as I said before. You can look at the past 7 years of history at a glance. Obviously, if a patient had a prescription for oxycodone given to him or her every single month, including the month that is being seen, you should not write additional narcotic. Here is an example of information that you can see in a PDMP report. And as you can see, this patient has been receiving OxyContin on a monthly basis for the last 7 years, and only one page of it is shown here. An important part of a comprehensive study of a patient is to obtain appropriate diagnostic imaging and testing, including any workup patient had, and the result of a blood workup, CT scan, MRI report, or any other important information. If opioids are to be prescribed for a chronic pain sufferer, the initial evaluation should include documentation of the patient's psychiatric status as well. Here are a few of the laboratory tests that could be obtained on a regular basis for patients that are medically complex prior to initiation of treatment, surgical treatment, or opioid treatment. The most common labs are CBC, CMP, platelet count, PT, PTT, INR, even urine analysis in some cases, and blood glucose level, and hemoglobin A1C, amongst many other lab results that are important to obtain. Now here's some really important recommendation. When you're writing opioid for acute pain, prescribe the lowest effective dose of a narcotic. Prescribe amount to match the expected duration of the pain, the type of procedure, expectation of anticipated pain that could be severe enough to require opioids. General recommendation is to write a narcotic if needed for about 3 days or less, and rarely more than 7 days. It is extremely important not to prescribe additional opioid just in case you had some more. You may say, I give you a refill. That should be avoided. Reevaluate patient with severe acute pain that continues longer than expected duration to confirm or revise the initial diagnosis and to adjust management accordingly. Possibly obtain additional x-ray if needed to make sure to see any issues, and also to making sure that you see the patient as well. For chronic pain management, ensure patients are aware of potential benefits, harms, and alternatives to opioids. Be explicit and realistic about expected benefits. Emphasize goals of improvement in pain as well as function. Discuss serious and common adverse effects of opioids. Discuss the risk of overdose are significantly increased in higher doses with patient, or if opioids are taken with other drugs or alcohol, the risk is much more serious. Once again, I have to say that when you are writing opioid, start with the lowest dose, reassess the patient as often as possible, and please use the PDMP. That's a crucial point and is so helpful to look at those numbers. Risk to the family member and individuals in the community should also be discussed. Certain factors increase risks for long-term opioid-associated harms. Avoid prescribing opioid to patients with moderate to severe sleep disorder breathing or sleep apnea when possible. The same with during pregnancy. Carefully weigh risk and benefit with patients. Use additional caution with renal or hepatic insufficiency for patients that are 65 or older. As I discussed in the last presentation, the first line of pain management, particularly in dental practice, should consider non-steroidal anti-inflammatory drug or NSAIDs unless contraindicated. NSAIDs have been demonstrated to be very effective for the treatment of dental pain and indeed are often more effective than opioids. My personal observation has been that majority of oral surgical procedures performed using a combination of NSAID and acetaminophen works best without the side effect of narcotics. You may consider giving a selective NSAIDs like Celebrex to avoid increased risk of bleeding. Since NSAIDs are the most commonly prescribed and recommended pain medication at present time, I like to review drug interaction of NSAIDs with blood thinners in particular. So let's get familiar with the new generation of anticoagulants. The risk for bleeding is obviously significantly increased when NSAIDs are used in combination with other anticoagulants including aspirin, Coumadin, Plavix, Xarelto, Pradaxa, and Eliquis. These anticoagulant drugs' effect last at various time periods. Majority of the new generation of anticoagulants work by inhibiting factor 10A function. They include Levodox, Xarelto, Eliquis, Pradaxa, and Plavix that their effect lasts for only 24 hours. Agranox, the effect of it lasts for 5 to 7 days. Persantin, the effect of it lasts for 1 to 3 days. Brilinta, the effect lasts up to 5 days. And again, these are factor 10A inhibitors. On the other hand, aspirin, which blocks cyclooxygenase 1 and 2, lasts for up to a week after use. Coumadin is a vitamin K antagonist, and the effect of it lasts up to 4 days later. But heparin, which is an antithrombin drug, lasts only for 5 hours after IV administration. So it is important to understand the anticoagulant interaction with NSAIDs, and all of these anticoagulant effects will be potentiated if we prescribe NSAIDs. I have to also add that there are other drugs which could prolong bleedings in addition to aspirin, ibuprofen, and anticoagulants. Certain antibiotics, alcohol, and even anti-cancer agents can also increase bleeding. On the other hand, we have some patients that also take multiple natural substances as supplement or in their diet that also are natural anticoagulant. They include cayenne pepper and ginger, which contain salicylate, just like aspirin, which is salicylic acid. Turmeric, the active ingredient in turmeric is crochronium, that has anti-inflammatory and blood thinning or anticoagulant property. Interestingly, cinnamon contains coumarin. Warfarin is derived from coumarin. Fish oil, willow bark, red clover, oregano, chamomile, ginkgo biloba, to name just a few other anticoagulants. An important point to remember is to take extreme caution in patients with history of hepatic or renal impairment, or who reports a previous adverse reaction to acetaminophen or NSAIDs. As I said, combination of acetaminophen and NSAID should be considered strongly. But how about acetaminophen? Acetaminophen has shown to be synergic with NSAID with the efficacy of low-dose opioids. But the maximum over-the-counter dose of acetaminophen is 3,000 milligrams per day in adult. That's 6 capsules. Maximum prescribed dose of NSAIDs, usually given as ibuprofen 600 to 800 milligrams, is 3,200 milligrams per day, but maximum over-the-counter dose of NSAIDs, such as Advil, is 1,200 milligrams per day. That's 6 capsules or tablets a day. Occasionally, I see patients that they take 4 of the over-the-counter Advil every 4 hours. You should advise them to read the label. It is written on every bottle of this medication to only take 6 per day. That will be 1,200 milligrams per day. It is true, however, as a provider, we can write a prescription of ibuprofen for twice that amount, but our prescription is for limited time use only. But if a patient receives a bottle of ibuprofen with 100 Advil in it, they would keep on taking that for a long period of time, and that could be extremely harmful for them. As I discussed in previous presentations, there are many other options to control pain. For example, for neuropathic pain and fibromyalgia, the following medications are prescribed: Neurontin, Lyrica, amitriptyline, nortriptyline, Cymbalta, Effexors are amongst few of the medications that are used. Topical agents such as lidocaine dermal patch and capsaicin cream are used to treat pain as well. So let's review this to make sure that we understand the strategy that you have to use for opioid treatment. The dosage and duration of the treatment should be for a short period of time, 3 to 5 days, and for conditions that typically are expected to be associated with more severe pain. Choose the lowest potency opioid necessary to relieve the patient's pain. And avoid long-acting opioids or extended release preparation for the treatment of acute pain. Interactions with other medications can either increase or decrease the potency of certain analgesics. When we talk about drug interaction, there are certain drugs that can interfere with the metabolism of opioid and can increase the risk of adverse effects or even adverse events. Antidepressants, for example, are among those drugs. Examples of antidepressants are Prozac, Zoloft, Paxil, Lexapro, and Celexa, that they interfere with the metabolism of opioid and increase the risk of morbidity. Opioids should not be used in combination with benzodiazepines, such as Xanax or Valium or other centrally acting sedating or narcotic medications due to increased risk of serious adverse effect, including death. An unfortunate recent incident was death of Prince, the famous singer, who died at age 57 from overdose of prescription medication, fentanyl and Valium. It is important to remember that you should avoid prescribing opioids to patients with prolonged complaint of pain without clear evidence of ongoing pathology. Refer patients out when they request continuation of opioid beyond the expected time of recovery. And if we look at the news, we see many times, unfortunately, dentists are accused of illegally prescribed opioids prescription for patients that they have not seen, they have not treated themselves, or in some cases they wrote prescription of narcotic for themselves or for their staff without exact diagnosis of what is the problem or without any basis. As I just said, it is important to know that about 12% of opioid prescribed come from the dentist. So please avoid writing more narcotic for patients who are receiving chronic opioids or who have a history of substance use disorder or who are at high risk of aberrant drug-related behavior, and our goal should be to save a life. And that's basically why I put these lectures together. If I could save a single life, I've achieved my goal. In a recent study, it was noted that about 85% of overdose death in Pennsylvania involved opioids. One of the other issues is, please don't send a patient to the emergency room to receive narcotics. Each day, over 1,000 people are seen in the emergency room requesting opioids from ER physicians that are overwhelmed with many other major issues. Please refer to my previous lecture regarding safe disposal of narcotics to keep families safe and provide instruction to patients on safe disposal of unused medication, including opioids, to ensure these medications are not available for possible diversion or misuse. Just to review that briefly, what should patients do to discard excess narcotic? FDA does not recommend returning medication to the practitioners for sure. They recommend transfer of unused medications to DEA authorized collectors for disposal. And I do ask you to check with your local hospital or pharmacist to see where are the sites that you should guide your patients to. FDA also does not recommend flushing them in the toilet. There's actually an FDA flush list instruction online. Instruct patients to never keep medications for future use. U.S. Drug Enforcement Agency, or FDA, has established the Narcotic Drug Take-Back Day. I do recommend to check that day and advise your patients about that. So here's my advice for prescription writing documentation. Limit refills of narcotic or just write "do not refill" on the prescription or on the digital submission. Document every time and document the reason for refilling the prescription. Ask patients to come in for reevaluation. If there's any question of continued pain, they need to come in. Never call a prescription for a patient that you have never seen, and I'm going to repeat this again and again. 10 days of continued symptoms. You need to have the patient come back, take an x-ray, and to assess what is the problem. Fear of writing medication to manage pain unfortunately has caused some patients to rely on street drugs and making drug addictions much worse. Use of oral steroids such as Medrol dose pack is a good choice. Then you can advise the patient to follow the instruction on the package. I have used also Decadron or dexamethasone 4 milligram tablet, only 8 of them, to be used every 8 hours to reduce the swelling and manage the pain. Also, we can use a longer acting local anesthetic as well. Here's a question. Which one of these are longest acting local anesthetics? Xylocaine with epinephrine, Procaine with epinephrine, Marcaine, Exparel, or Expedia? Unfortunately, you are not in my courses to get my sense of humor, but which one of these do you think is the longest acting local anesthetic agents? Interestingly, a new generation of local anesthetic is now available for use and is called Exparel. Exparel is a long-lasting non-opioid analgesic that could be used used as part of a multimodal approach to pain management. It could provide post-surgical pain relief and help reduce the need for opioid after surgery. Basically, Exparel is a long-acting Bupivacaine that is used for injection to the surgical site. It incorporates time-release technology called depo-foam. Depo-foam is a liposome that engulfs Bupivacaine without altering the Bupivacaine's structure and releases Bupivacaine in an extended release mechanism. This delivery of Bupivacaine through a mass, also called liposome vesicle, is called a depot injection. This illustration shows encapsulates Bupivacaine in multivesicular liposome and how Bupivacaine is slowly released throughout time with the degradation or absorption of the lipid membrane once injected to the surgical site. This process prolongs the duration of action of Bupivacaine. Exparel was approved for other medical use earlier, but in 2015 it was approved for oral surgical procedures. Pain reduction between 0 to 24 hours post-surgery, used to decrease opioid usage in surgical patients from 0 hours to 72 hours post-operatively. There's very low systemic exposure and greater safety profile by this slow release of Bupivacaine or Marcaine. Based on the Exparel website, the indication encompasses use for post-surgical analgesia when administered as local infiltration at the site of oral surgical procedure, including tooth extraction. The indication also includes use as a local anesthetic deposited near a terminal branch of maxillary or mandibular branch of the trigeminal nerve in form of preapical injections. Exparel should be injected with a 25 gauge or a larger bore needles. It is best administered using a frequent and consistent injection technique throughout the surgical site. Exparel readily diffuses into the surrounding tissue and is spread throughout the site. It requires fewer injections for adequate pain receptor coverage. Now let's look at Exparel versus Bupivacaine with epinephrine. Exparel, as far as pain reduction, reduces the pain up to 24 hours. Bupivacaine, up to 6 to 8 hours of pain reduction. Half-life for Exparel is 23.8 up to 34.1 hours, and half-life for Bupivacaine is 3.5 hours. Duration of anesthetic for Exparel is up to 24 hours, and with Bupivacaine is 6 to 8 hours. The onset of pain relief or anesthetic is about 5 minutes for Exparel, and is the same with Bupivacaine, 5 to 10 minutes. Time to peak plasma level for Exparel is 30 to 90 minutes, and for Bupivacaine is 30 to 45 minutes. Compare Exparel with Bupivacaine one more time as far as the price. Bupivacaine is about $2.80 for a vial, and Exparel is $285 for one vial. And the company claims that it is covered by some insurances. Exparel is 266 milligram per ml in 20 ml single patient use vial. Dosing is based on coverage of surgical site, not body weight. And Exparel could be diluted in up to 280 ml of sterile saline to increase the volume. And as I said before, Exparel should not be used for mandibular block. It's used for infiltration only. Finally, the relationship of sleep apnea and opioids. I've done research on sleep apnea for years and have written books and chapters for different books on this subject. So let's explore this a little bit more in detail. Opioids can increase risk of obstructive sleep apnea, leading to cessation of breathing. This is created by causing a relaxation of the tissues in the upper airway once the opioid is used, and hence blocking the airway. Chronic opioid use has been associated with development of a sleep disorder breathing, such as central sleep apnea. Patients receiving chronic opioid may suffer from unrecognized sleep apnea that contributes to opioid overdose death. In these next few lectures, I'm going to repeat what I have said in this presentation and in the last 4 other lectures. So we're going to put everything that we have learned together. So first thing is to conduct a thorough medical and dental history, documentation of current medication list, use prescription drug monitoring program or PDMP on a regular basis, identify past use or abuse of controlled substances, assess possibility of addiction, identify the exact diagnosis where this pain is coming from, discuss your plan of treatment in detail, including realistic goals for pain management, provide an estimate of anticipated pain duration, and do not underestimate. When a patient comes to me for, let's say, removal of third molars, I don't want to tell them that your pain would only last for 1 or 5 days. I actually tell my patients that after 5 to 7 days, you may develop more pain. Your pain may come back at that time, and be prepared. And at that time, basically you just take ibuprofen if you're not allergic to that or there's no side effect for that. So we need to explain that to the patient. Make sure patients and family, if minor, agrees with the treatment and obtain a consent form. American Dental Association have provided us with informed consent and controlled substance agreement consent form. And it reads like this: I, patient's name, understand and agree to follow, doctor and your name, the policies regarding the use of opioids, narcotic, and other controlled substances for management of chronic conditions. I understand that doctor, your name, is under no obligation to prescribe these medications for me. I also understand that breaking the terms within this agreement may lead to its termination of my dismissal from treatment. Then it continues to say that I have tried other medical treatment which have not worked to control my condition. The doctor has recommended that I be placed on a course of medication to help manage my symptoms and to improve my ability to participate in my activities of daily living, whether it's work or family and so on. I also understand that these medications are not expected to entirely eliminate all of my symptoms, but are intended to help me to improve my quality of life. This is a decision that I have made after fully discussing the risk, benefit, as well as alternative to this treatment with my doctor. And then the patient signs, or if there's a younger patient, a legal guardian would sign that form. Why are you listening to this course? Basically, our goal is to reduce prescription drug abuse. And that prescription drug abuse could be reduced by following these additional recommendations. Prescribe for legitimate dental purposes only. Prescribe only for patients of record. As we said, periodically update pain management training by attending courses or listening to lectures like this. And by the way, in the state of Pennsylvania, it is mandated that all licensed individual that have DEA license and they write narcotic prescription to take courses like this every 2 years. Discuss and follow up with patients regarding proper compliance, storage, and disposal of the opioids and other drugs. Consider non-opioids, preemptive medications. Monitor balance between pain relief, function, and safety. Train office staff. Never prescribe without proper patient treatment. Safeguard prescription pad if you still have prescription pads. Learn to identify high-risk substance abuse patients. Require photo ID, confirm telephone number and address of the patients. Limit quantities of narcotics that you're writing in and write it in numeric and textual. Also address the cause of continued pain. Give adequate local anesthetic and use long-acting local anesthetic if possible. Remember, Marcaine or Bupivacaine could not be used for children, young children. Use of appropriate analgesics such as NSAID as the first line of treatment. Consider steroid treatment. Consider NSAIDs prior to the procedure. Remember, NSAIDs can prolong bleeding in patients on blood thinners, including baby aspirin. Monitor for adverse reaction to NSAIDs in patients with history of renal diseases. Prescribe medication only after evaluating the patients face-to-face. Do not prescribe any narcotic to patients that you have never seen. When opioids are started, prescribe the lowest effective dosage, as we discussed many times during this course. Before starting opioid treatment for chronic pain, establish treatment goals, including realistic goals for pain and function, and should consider how therapy will be discontinued if benefit does not outweigh the risk. Consider opioid treatment only if expected benefit for both pain and function are anticipated to outweigh risk to the patients. Finally, know the behavior characteristic of drug-seeking patients. patients that they come in and requesting specific opioids, or they claim that they're out of town or out of this area and they were just passing by and they have this severe pain and they need narcotics. Or if they refuse treatment by only request medications, I just need pain medication and I come back later. Request early refill of their medication. I lost my medication. My dog ate it. It was dropped in the toilet. It was a stolen prescription. Or they come in with made up pain. Usually they are very irritable, hyperactive, malnourished, non-compliant, or appear impaired or sedated. Do not prescribe extended release opioid for acute pain treatment. If no addiction or concerning history, treat adequately and for enough time. If addiction history, may need aggressive treatment, but short duration. I hope you have learned few points from this series of presentation. My goal has always been to share my knowledge with my colleagues and contribute to their continuing education. I hope that I was able to achieve that goal. Thank you so much for your attention. If you would like to receive CE credit for these courses, please visit our websites at www.snorenet, that's SNORENET.com, or contact the Bala Institute of Oral Surgery at 610-667-4455. And don't forget to subscribe to our YouTube channel to receive updated information on a continuous basis, as we are going to cover many other subjects of interest and importance to dental practices. Have a great day.